The next session, we'll hear from the awardees of our competitive and much coveted BSET fellowships. And we're going to start with Badri Vijaynagar, our traveling fellow for 2022.
Thank you. So I went to Terma in Italy as a part of my BSET traveling fellowship, and that's in north part of Italy. And I chose it because they are the specialists in diabetic foot care, and I was interested in learning the pedal revascularization under them. And these are the supervisors I work with, Marco Manzi and Mariano Pelana, who we all met in different meetings. So why did I choose Terma? It's because it's one of the institutions where they had a wide spread practice of diabetic foot revascularization. And they do roughly about 800,000 cases per year. And it's mainly devoted to diabetic foot disease. And therefore, I had an opportunity to go and learn not only the endovascular skills, but the setup they had to revascularize the pedal arch. So what did I learn from them? I think the simplicity was the core of what I learned there. Their kit, what they used was very minimalistic. They had very few catheters, very few balloons, but they were all specialized to each needs. They would not use hundreds of wires and balloons which I've seen used in other places, but the minimalistic attitude was which struck me when I saw them working there. They had standardized process for almost every part of the procedure. They had always used a micropuncture kit, ultrasound guided 6-pin sheath, all diagnostic runs using AngioDroid, standardized projections for the profunda, for the SFA, trifurcation, and the crural, and always an AP and a lateral foot view for all patients. All these are standardized, so when they present, you got the images almost on a standardized basis. And they used perfusion angiography in all patients to show that the angioplasties that they've done has worked in them. And of course, there is a debate about perfusion angiography, whether it means anything or not, but they use it as a standardized process. And angiography for everyone so they can get through patients a lot more quicker. So what's new in Terma compared to other places where I have been trained in endovascular techniques? And I think the perfusion angiography was new to me. And always, because of the diabetic foot disease, the crural disease is a lot more calcific. They tend to use a lot more non-compliant balloons than the semi-compliant that we use in my training. And almost always have a pedal arch view as a marker for a runoff for crural vessel angioplasties. And that's important for us because many a times we see people doing crural angioplasties and go to the ankle level and they say, we got foot up, ankle level is good. But that doesn't hold good, especially in diabetic foot patients. And that was an important marker for me when I saw them doing this pedal arch angioplasties. Bidirectional approach is a lot less time consuming, and I've seen trainees there doing a bidirectional approach, retrograde access, and they're very good at it within 3 to 6 months. I think it's a basic approach that we need to change when you're going for bidirectional approach, and it's not difficult. Every procedure we think will be finding it difficult if you don't have the approach to it. And I think bidirectional approach is a great way of revascularizing lower limbs, especially in diabetic patients. What did I learn at the end was to keep it simple, standardize the procedure, and always have build a team around you. There are 2 people, Mariano and Marco Manzi, who do all the work, and they have a very limited team. There are 4 people working with them, and they do the whole procedures, up to 6 procedures a day, without any problems. And that is, building a team with you increases efficiency. And also, they are ready to change and embrace the new things that are coming into the system. Although they do very good pedal angioplasties, they never used shockwave lithotripsy until a few months ago, but they're happy to change and embrace so that they can innovate and improve their efficiencies. So I went to London as a part of my BSET endovascular fellowship in 21, and I went to Italy in 22. And after all these fellowships, what did I actually do in my training is important, because going to fellowship is one good thing and applying it to my clinical practice is another thing. So these are the few things I'm going to show what I learned there. This is an acute limb ischemia in my first month of on-call. This is a young lady who did not want a bypass surgery, and I did a thrombectomy and stenting of that. And after 3 months, 6 weeks and 3 months, she's got a triphasic sickness at the ankle. And I could do this because I went to these fellowships. This was an instant occlusion of a previously placed superior stent, and I opened it up again with a jet-stream atherectomy and a distal addition of a superior stent, and had a good signal at the ankle within 2 months of my job there. And this was the latest one, which I did a couple of weeks ago, where I had a lady, 94-year-old, who was unfit for common femoral endarterectomy, where I did a retrograde access and did a IVL lithotripsy for the common femoral artery, and leaving nothing behind strategy was used, and the patient went home the following day. So these are the real benefits that we get from endovascular training. And I presented Thanos' results of instant occlusions last year, and I was asked a question by the chair, quite rightly: how could you generalize these techniques when it's done by one specialist endovascular surgeon? Then I said to them that we're doing these endovascular fellowships, and exposure to training equips you with all the tools that you need to work as a complete endovascular surgeon. And that's why I thank BSET team for having allowed me to go for these fellowships and learn the techniques. Thank you.
Thank you, Badri. It was an excellent summary of your double fellowship with BSET. Unfortunately, we're running behind time, and we'll talk with you at lunchtime.
Thank you.
Thanks.
So it's now my pleasure to welcome Ummul Contractor, who's made the move from Wales up to the joys of Leicester for her training fellowship. Tell us all about it.
So good morning, my name's Ummul Contractor, and I'm currently a trainee in Wales. I was lucky enough to be awarded the BSET fellowship, which I undertook in the Glenfield Hospital in Leicester. So my aims of why I wanted the BSET fellowship: as we know, endovascular training varies quite vastly across the nation. My personal experience in Wales had a lot of good open experience, quite poor peripheral endovascular experience, poor exposure and inconsistent. This, coupled with the fact that we have a very large burden of crural vessel disease in Wales, a lot of diabetic disease and high rates of amputation. For me, the fellowship in learning endovascular skills was more than just a tick box CCT exercise. I really wanted to be able to apply things into my clinical practice and be able to practice as a consultant, as an endovascular consultant. The choice of the Leicester Vascular Institute was fairly obvious. It's a centre of excellence for what I was looking for. My focus was mainly on peripheral endovascular procedures. So my plan going there was to consolidate the few existing skills I did possess, learn new skills, build a wider repertoire, and make plans for the future, building networks and friends. So like they said, it's a long way from Cardiff to Leicester. It's a 300-mile round trip, but I've got it down to a fine art now. Bit of planning required on the home front. So abandoning the family for a week needed a bit of planning. However, when I got there, I felt welcome from the start. Found a pair of clean clogs which fit. As Lawrence will be happy, found leads which were the appropriate weight and fit me as well. Given lead protection glasses, and also my own personal irradiation badge. So just when I thought things couldn't get better, here are my highlights. So I ended up working with one of the founding fathers of subintimal angioplasties while I was there. And I looked for and found lots and lots of crural work. And while I said my main focus was peripheral endovascular, I've ended up participating in a lot of FEVARs, TVARs, and IBs during my time there. And what I call new technologies is stuff like IVL shockwave, which is not new to everybody, but it was an eye-opener for me. And the best part of it was working with probably the most friendly and welcoming angio suite team that I've ever experienced. So I'm in my 5th month at the moment, still got a month to go. However, I feel that I'm independent with some angioplasty procedures. My confidence with antegrade punctures has come a long way. I've got a better understanding of the kit, of how to troubleshoot, how to, what is appropriate for what needs. I've also managed to experience subintimal angioplasties and getting over the uncomfortable feeling of being in the subintimal space. And all of this has led to a very healthy logbook. So this is what it looked like before. This is where I am after. So just a snapshot of what I've achieved in the last 5 months. So finally, I really want to thank BSET for providing me with this opportunity, and especially Jeanette for being a troubleshooter and a lifesaver in most cases. So thank you very much. A quick thank you to my family for tolerating 6 months of abandonment and neglect. And finally, a very big thank you to the consultants who've given me opportunities and trained me, the junior doctors who helped me find my feet in the logistics of the hospital, and the staff there for making it a very pleasant and enjoyable experience. Thank you.